Hello, everyone. I'm Jiahui Xin, a visiting PhD student at MRC Biostatistics Unit, University of Cambridge. And I'm happy to give the talk about the single-arm trial. It's based on my internship at Dallas Pharma. First, I will describe the background of the single-arm trial. And regulatory authorities like FDA, EMA, and CDE, they share the perspectives on the single-arm trial to accelerate the oncology drug development. And in 2023, FDA approved the EFMO for the pediatric neuroblastomas. That's the first time the FDA has relied on a single externally controlled trial to support approval in oncology. And the externally controlled trial means even though we are conducting the single-arm trial, we also select one external control, and we want to make the indirect comparison, even though we are not conducting the RCT. And from the pie chart, we could see the most widely used method is MAIC, the weighting method. Actually, we can do the naive comparison, but because the covariate shift between the external control and the internal trial, the naive comparison may lead to the selection bias. And the MAIC means the matched adjusted indirect comparison is a weighting method. It weighs the internal population to align with the external control to make the fair comparison. And the evidence generation workflow for the single-arm trial is as follows. First step is to define the S-mod. In our case, it has a ratio between the external control and the internal trial. And the second step is to select the external control. Mostly it will be from some publication or technical reports. And the final step is to use some weighting or matching method to adjust the covariate imbalance. But the existing retrospective method has some challenges. The first challenge is about the difficulty to plan the trial, because if there's no covariate shift, we can use the standard sample size calculation. But there is unknown baseline imbalance before the trial, so it will be hard to decide when to stop the trial. And the second challenge is about the power loss, because we are using the weighting method and we assign the unequal weights to unit. That may lead to power loss, especially when the baseline imbalance is severe. And our method is easy to understand, the Covariate-Adaptive Enrolment. At first, we need some patients to burn in, and we treat all comers in this stage. And the adaptive stage, we for each incoming patient, we ask the question: will the patient decrease the incurrent imbalance? If the answer is yes, we enroll him or her as a higher probability. But if the answer is no, we enroll him or her as a lower probability. And by this, we can sequentially minimize the covariate imbalance. We also conduct some hypothetical survival trials. We consider two covariates. First is prognostic factor, and the another is the predictive factor. We consider 4 shift settings: no shift, predictive factor shift, prognostic factor shift, and both shift. We compare 3 covariate adjustment methods. First is CAE, our proposed method, and the another 2 is the existing weighting method. And we could see the CAE maintained the power in every coverage shift settings, but the weighting method has different levels of power loss, and the shift level increases, the power loss will be greater. So that's all. I also have the poster presentation. We could have a chat if you have any questions or comments. Thank you.
So if you stay here, and we'll get Quinn to come up again. Where's he gone? Okay. Does anyone have any questions for Jesper or Jiahui?
I have the okay.
Go ahead. So what is your method? Yeah, what is your method?
What is my method?
Yeah.
It's a design method. It's an enrollment stage strategy.
I see.
Yeah.
So did you have a question?
How is that defined?
So can you repeat the question?
Yeah. Do you mean how to define the covariate imbalance, or?
Like if you don't know the patient because they're
yeah.
choose and bias involve patients that are similar, very small. Very service.
Yeah, I got it. Actually, you can also keep the patient without enrollment. And if you want to estimate the absolute metric like the ORR, you can use the whole patient. But if you want to make some comparison, you could use the sub-trial, subpopulation using this strategy. Yes, it's an issue about the, maybe you can only enroll a small subset of the whole screening patient. Yeah, and we are working on the dynamic enrollment probability about that question, because if in that case the enrollment probability is fixed, like 0.3 and 0.9, but you can, if the coverage shift is small, you can increase the enrollment probability, and in that case you can maintain a relatively high patient number. Yeah, thanks for your question.
Okay. So let's thank all our speakers again.